Alrighty, this is intended to be a brief educational video so that you feel confident using ultrasound in the assessment of traumatic patients in the emergency department. My name is Sally Graglia. I'm one of the current Mass General Ultrasound Fellows, and you and I will be working together throughout your rotation to make sure that you feel confident using ultrasound in the assessment of traumatic patients. So first of all, you will hear people use the term fast or effaced loosely in the department. You don't know what they're referring to when they use these statements, so we're going to advocate that you don't use the term effaced or fast. Traditionally, when we use ultrasound in the assessment of traumatic patients, we're looking for evidence of bleeding, right? So we're looking in the abdomen for evidence of free fluid. We're looking in the chest for evidence of either hemothorax or pneumothorax as a result of trauma. And we're also looking around the heart for evidence of a traumatic pericardial effusion. However, when you tell me that you did a fast, does that mean that you looked in the right upper quadrant, the left upper quadrant? What about the pelvis? Did you look in the right thorax, the left thorax? Did you look at both anterior lung spaces for pneumothorax? We don't want there to be any ambiguity when it comes to the assessment of traumatic patients. So we're going to advocate that instead of using words like fast and effast, we want you to say what you found. So for example, the right upper quadrant and left upper quadrant are negative for evidence of free fluid. Or there's no evidence of pneumothorax on the bedside ultrasound. There's no evidence of a pericardial effusion, or there's no evidence of a hemothorax on bedside ultrasound. These statements will make sure that the trauma attending, the trauma residents, the ED attending, the ED residents, the nurses, everyone will be on the same page about what has been assessed and what has been found. So whenever you're using ultrasound in the emergency department to assess our traumatic patients, generally you want to use either the curvilinear probe or the phase array probe. Why these probes? It's because they're both low frequency, meaning that the wavelengths actually travel deeper into the body and will help us visualize deep structures more easily. Traditionally, we start in the right upper quadrant. And again, in general, this is the curvilinear probe with the indicator towards the patient's head. You start in the mid-axillary line, about 5th or 6th rib space. And what are you looking for? You are looking for this. So this is the liver. This is the kidney, the right kidney. This is Morrison's pouch or Morrison's space between the two. That is a potential space. This is the diaphragm. So this bright white curved line is the diaphragm. And this along the posterior aspect of your screen is the spine. If you notice, you cannot see anything behind the diaphragm. And that's because this is all lung. Ultrasound doesn't travel through lung or bone. It doesn't travel through lung because the lung scatters ultrasound waves. And so if you notice where the diaphragm kind of inserts here, it's like a curtain, and every time the patient breathes, you can't see anything behind this diaphragm curtain. This is the spine. If this patient had bleeding into the chest with a hemothorax, there would be anechoic fluid here, and you would be able to see the spine continue because the ultrasound waves coming from the probe happily travel through fluid. That is not happening here. This is a normal right upper quadrant. So for example, here, what are we looking at? This is the liver, this is the kidney, and this black stripe is intra-abdominal free fluid. What about here? So again, this is the liver, this is the kidney, this is that spine we talked about, and notice how different this is than what we were looking at before. First of all, let me say there's no evidence of free fluid in Morrison's pouch here. But what do you see? You see that spine continue beautifully up. The reason that you can see it is because this anechoic fluid is a friend to the ultrasound, and the ultrasound waves travel happily through it and hit the spine. This is a positive spine sign. In the setting of trauma, this is a hemothorax until proven otherwise. So after we evaluated the right upper quadrant, we go to the left upper quadrant. In the left upper quadrant, just like the right upper quadrant, you're interrogating the splenorenal space. So in the right upper quadrant, you were evaluating Morrison's pouch, the diaphragm, and the inferior tip of the kidney. Here in the left upper quadrant, you're evaluating the diaphragm, the splenorenal space, and the tip of the left spleen. Again, curvilinear probe, indicator towards the patient's head. Because the spleen is smaller than the liver, These structures tend to be very retroperitoneal, so you're going to have to put knuckles to the bed aiming up to find the structures you're looking for. This is an example of a normal. This is the spleen. This is the kidney on the left. This would be the splenorenal space. This is the diaphragm, and if you notice, you can't see anything above the diaphragm. That's normal. This is the spine in the far field. I don't see any evidence of fluid here. I don't see any evidence of fluid here. Obviously, you want this to be a clip and not a still image. For example, this operator was interrogating the splenorenal space and also the tip of the kidney here. So there's no fluid in the splenorenal space, and I don't see any evidence of free fluid here. What about this image? So this is the diaphragm that you're seeing at the edge of your screen. This is that beautiful spine. This is the left kidney, and this homogeneous organ is called the spleen. This anechoic stripe is free fluid, so this is a positive evaluation for intra-abdominal free fluid with a positive left upper quadrant for free fluid. This again is another positive study. Here is the spleen. I'm assuming the kidney somewhere down here. I haven't seen it yet. This is lung. That bright white line is the lung. And then there's something happening back here. Right here, you can see this anechoic triangle, and the diaphragm is here sitting on top of the spleen, and this is a continuation of the spine. So this is a positive spine sign. This patient has a positive left hemathorax. When we're done with the left upper quadrant and the right upper quadrant, you want to look in the pelvis for evidence of free fluid. So this operator started in the transverse plane and is currently in the longitudinal plane, head to toe. Indicator is towards the patient's head. So they've just gone back to transverse, and they'll flip, there we go, longitudinal, fanning from left to right, looking for evidence of free fluid in the pelvis. The minimal criteria for the hammer program is looking in the longitudinal plane, fanning from left to right. So this is a transverse sweep through the bladder. This anechoic filled sac is the bladder, and I don't see any evidence of free fluid posterior to the bladder. Here, however, you can see that when you fan through, all of this in here is free fluid. Deep or posterior to the bladder, you will see free fluid. Some people say that free fluid has kind of sharp edges, and that's because free fluid fills whatever space it's given. This is a very interesting study. So this first part of the clip is the bladder. And then as you go forward, this is all free fluid, as is this. This is a female patient because this is the uterus and those are the fallopian tubes extending out in each direction. This person has a tremendous amount of free fluid in the abdomen. This is all bowel. Finally, when you've evaluated left upper quadrant, right upper quadrant, and the pelvis, you want to look at the heart for evidence of pericardial effusion. Traditionally, in the FAST, it's taught that you use the subxiphoid view. So the xiphoid process is about here, kind of the most inferior aspect of the sternum. You put the probe on the patient's upper abdomen. If you notice, the operator's hand is above the probe. That's so that they can flatten the probe against the patient's body, angling up into the chest because we're looking for the heart. This is what you might see. So this is the liver here. It's being used as what's called an acoustic window. This is the right ventricle, the left ventricle, left atrium emptying into the left ventricle, and right atrium emptying into the right ventricle. If there were free fluid, you'd see an anechoic, or if there were pericardial effusion, you'd see an anechoic stripe along that right ventricular heart border where it interfaces with the liver. This is an example of a positive pericardial effusion. That heart is kind of moving freely in this sac of fluid, and all of this anechoic fluid is pericardial effusion. Finally, in the traditionally taught effaced or extended fast, you're also looking at the thorax for evidence of a pneumothorax. This is the linear probe. You want to use the linear probe when you're looking for evidence of a pneumothorax because it is a high-frequency probe, which means that the wavelengths don't travel as far and you can see superficial structures with better resolution. So you want to evaluate the right chest and the left chest, and you want to evaluate in places where air would be. So in a supine patient, which generally most of our trauma patients are, You're looking in the anterior chest, between the nipples, just above the nipples. In a patient who's sitting up, where's the air going to go? It's going to go towards the clavicles, so you'd look much more superior in a patient sitting upright. This is what you might see in the supine trauma patient. So this is a rib with rib shadow. This is a rib with rib shadow. We're at 8 centimeters of depth here, and we could actually make this a lot more superficial for what we're looking for. This is all the skin and the subcutaneous tissue here. And then this, if you notice, you can see that movement along that line. This is the pleural interface. This is the visceral and parietal pleura and where they slide against each other. You can see the lung moving with every breath. This is a normal assessment of the thorax. There's no evidence of a pneumothorax here. What about this? So here, if you notice, here's a rib, here's a rib. And in this first part of the clip, there's zero movement. There's some movement there. So there's zero movement here along that pleural interface. Here you can see some sliding, no movement, and some sliding. So that first part of that clip, whatever rib space they're in there, is very concerning for pneumothorax. And this is very interesting too. So this is that pleural interface, and this is normal lung sliding. The place where these two things meet, where you actually catch the edge of the pneumothorax, is called the lung point, and it's essentially pathognomonic for evidence of a pneumothorax. Finally, you can use Mmode in the assessment for a pneumothorax. So what's happening here? When you press Mmode on any machine, it'll drop a line down through the screen. When you press Mmode again, it'll produce this block. And this block is essentially showing you that line and everything that's happening at that line over time. And so, for example, this is a rib, this is a rib. This is about 2 centimeters of depth. Everything superficial to that pleural line is subcutaneous tissue. Everything deep to that pleural line is lung. So this is rib and rib shadow here. This is rib and rib shadow. And this is lung. So when the patient breathes, everything superficial to that pleural interface, again, I said about 2 centimeters, so about here, everything superficial here isn't moving because it's all subcutaneous tissue. But everything deep is going to be moving, and you get this kind of sandy appearance. This is referred to as sand on the beach. It's like you were standing on a coastline, and this is all the sand, and this is the beautiful horizon. This is a normal appearance of normally sliding lung with Mmode. This is different. So here again we have rib, rib, rib shadow, subcutaneous tissue, pleural interface, and lung behind it. At 2 centimeters, which is still about 2 centimeters, you get no movement superficial to that, but this is all flat. There's no movement. Compare that to this. So sand on the beach, but this is like a barcode or stratosphere sign. This is very concerning for a pneumothorax. Just remember that we're all here to support you on your rotation in the emergency department, and ultimately the emergency department attending is responsible for all ultrasounds performed in the emergency department. So make sure after every scan you do, no matter what your findings, you show them to the attending and make sure that the attending reviews them. Thank you, and I look forward to working with you in the department.